All right, it looks like everyone is connected. Thanks so much for joining us. We're so glad you're here. This is going to be an introduction to GPRA and SPARS with our SAMHSA GPOs today. And I'm going to pass it over to Kathy Tomlin to invite someone to offer a blessing.
Hello, everyone. This is Kathy from Oregon. I'd like to invite an elder or someone who feels inspired to offer us a blessing before we begin our presentation. So I'm going to open that up and just take your mic off and offer us a blessing. So I'll give us a few seconds to see if someone's available. All right. We will turn it over to our brilliant Will from SAMHSA.
Oh, wow. Thank you, Kathy. Yeah, I don't know about brilliant, but see if yeah. So hello, everyone, and good afternoon or good morning, depending on where you are today. Welcome to our TOR GPRA Data Collection Overview webinar. So today we're going to cover kind of an introduction to the GPRA data collection survey for the Tribal Opioid Response Grant, and how you'll upload and submit some of that data to SAMHSA. So a lot of this information will be aimed at new grantees. I know we have a number of you who just started with your TOR grants at the end of September, but I think if you have been with the project for a while, this will also be a good refresher for you. So happy to see so many of you here today. I see a lot of familiar names and faces. So let's see, we can go to the next slide. So presenting with me today are my colleagues, Brittany Barbara Alexander and Paul Kolchbrenner. And between the three of us, we manage the projects under the TOR grant. So hopefully you're in contact with one of us, working on your grant. So we can go to the next slide. And at this point, I'm going to turn it over to Paul Kolchbrenner, who's going to talk to us a little bit about some of the higher level aspects of GPRA, what it is, and what the purpose of it is. So, Paul.
Thanks, Will. Hello, everyone. Glad to be here. As the newest public health advisor in GPO, I'm still learning some things about GPRA myself, so I'm looking forward to this as well. But just from an overview perspective, GPRA, the Government Performance and Results Act, was originally passed in 1993, amended in 2010, and requires all agencies, all federal agencies, to develop an annual performance plan and annual report. So there is a reason why we have you do this. We want to be able to show, particularly members of Congress, that these programs are effective, and so they can keep funding them and hopefully increase funding for them. So yes, the GPRA data allows SAMHSA to determine the impact of the grant programs and uses it to report key outcome measures to Congress. Okay, next slide, please. Although there's many things that you guys are doing along the whole continuum of care, the GPRA data reporting focuses on two primary areas. The first being collection. Grantees who are purchasing, distributing naloxone or Narcan with TOR funds are responsible for reporting the number of kits purchased and distributed on a quarterly basis. And then the second one is the GPRA client instrument, which we'll be talking a whole lot about during this presentation. But this is where grantees providing individual treatment, including MAT and recovery support, with the TOR funds are required to report client-level data on elements, including but not limited to diagnostics, demographics, substance use services, type of MAT, and others. So the data that you provide as required by GPRA is entered into SAMHSA's Performance Accountability and Reporting System, or SPARS. Okay, next. Program level, GPRA program level data collection. All TOR grantees report program level data. Data will be collected quarterly. This is again going back to the naloxone Narcan. reported quarterly in SPARS, and information is due ideally 30 days at the end of each quarter reporting period. Next, more detail on the client level data collection. Client level data collection is required for all clients receiving treatment or recovery services. It is not required for prevention activities. There's three main points at which data needs to be collected. First is the baseline or intake, a 6-month follow-up, and upon discharge. There is no 3-month follow-up interview required. You will see that in SPARS. It's not required for the TOR grant. Follow-up interviews are required for every client, regardless of discharge status, if they complete or they drop out. And interviews may be done by phone or video conferencing, especially these days. Okay, next. A little more on the intake interview. Grantee should collect GPRA data on each client as soon as possible after the client's intake into the program. We were talking a little bit about this earlier. If you're a new grantee, ideally we'd like to see you start entering data into SPARS within the first 3 to 4 months after beginning your grant. Clients who drop out and return for a new episode of care will receive a new intake using the same client ID number. And grantees with clients transitioning from a previous TOR grant to a new TOR grant must complete a discharge under the old grant and then have a new intake under the new grant. And it shows here which sections you need to complete in that instance. Okay, next slide. 6-month follow-up interview. If a client is reached for an interview, complete, and tells you the sections to complete. If a client cannot be reached, which I know is often a challenge these days, you can complete a administrative follow-up, Section A and Section I. Ideally, we would like to see 80% follow-up rate. I know that is not always achievable, but that is the goal. And again, the more data we can collect, and the better in terms of being able to provide the data to Congress and other people who are interested in knowing about the effectiveness of this grant and these programs. Okay, next 6-month follow. More on the 6-month follow-up interview. Ideally, again, grantees have 90 days to complete the follow-up interview after the intake interview. 90 days after that 6 months, as you'll see on the timeline here. So you have an example where there's an intake interview on the 1st of January. The 6-month follow-up window begins May 1st and goes for 90 days, 3 months until July 31st. And again, these are goals. We know they're not always going to be met in every instance, but these are the kind of parameters we hope to achieve. Okay, next. Discharge interviews. For discharge policy, the first thing is you follow your own discharge policy, whatever your program has as this policy as to under what circumstances to just discharge someone. If a client is reached, you fill out Section A, B through G, and J through K. If you are unable to reach a client for whatever reason, you do what's called an administrative discharge, records management, and Section J and Section K. Okay, next. Okay, addressing confidentiality concerns. GPRA client data is de-identified as clients are assigned ID numbers by your program. Under HIPAA, there's no personal identifying information. The new client ID is designed to match the client's intake and follow-up interviews while maintaining the anonymity of the client. SAMHSA uses aggregate level data to develop reports, which are shared with U.S. Congress. Obviously, there's no personal information included in those reports. They're much broader. SAMHSA does not require internal review board approval for GPRA data collection, and clients may refuse to answer any or all questions from the GPRA interview. So we're going to get much more into that. And with that, I'm going to turn it over to my colleague, Brittany.
Good afternoon and good morning to everyone, depending on where you are. So I'm going to talk about the Section A, the Records Management Plan Services. So this is what it looks like in Section A. This is just a kind of quick screenshot of what you should see if you go into GPRA, if you've never seen it before or haven't been in there just yet, since everyone's just starting out for new folks. So this is kind of what it looks like. Obviously, just go down the questions and kind of just ask them one by one and check what is applicable to you and your program. You can go to the next slide. All right, this is a little more in depth about the behavioral health diagnosis. This, again, is intended on the questions to identify the client's current behavioral health diagnosis, if it's known. In this section, this is not really asked to the grantees. This is collected from the EHR or behavioral health record system. So you don't actually ask these questions directly to the grantee. You get this information elsewhere. Next slide. So this is the main part of the interview right here, the client level interview section. These are the questions that you ask in your interview here. During drug and alcohol use during the past 30 days, this is required at each interview. Family living and conditions over the past 30 days is also required at the first interview. Attendance of school, grade level completion, this is also required during the interview. And involvement with the criminal justice system is required at the interview. So each one of these sections, sections B, C, D, and E are all required questions to ask in the first section of the interview. Next slide. Okay. So I do want to put out this disclaimer that the person, whoever's conducting these interviews, if they're not a clinical person, if someone asks any one of the questions that are on the GPRA data, any section, if someone feels uncomfortable, they're allowed to not answer the question or skip it if they feel uncomfortable in any way. And hopefully someone that is asking these questions who are non-clinical will refer them to someone else afterwards to get additional support, with counseling or help if they need anything, especially if they're triggered by any questions. We should also put that disclaimer out there that these questions are asked to everyone who comes in for these type of interviews. So just want to note that. But continuing on, mental and physical health problems of treatment, recovery, and violence and trauma, that is asked under Section F. Again, that is a very sensitive section. We'll talk a little bit more about that later. But you do ask that and is required in interviews. Social support network of the provider is also required. And in Section 8H is not required at all for grantees. Next slide. Okay. These are sections that are supposed to be completed during follow-up and discharges. So Section I, again, is completed at the follow-up by the interview, but not asked to the client directly. It's required regardless if the interview was conducted. You will probably have this information already, so you can quickly answer the questions. Section J is only completed at discharge, completed by the interviewer, and again, not asked to the client. It's just required regardless if the interview was conducted or not. So again, we're trying to collect data here, so we want to complete the task for discharge. And then the last section K here is completed at discharge and completed by the interviewer and also not asked to the client. And this still is a requirement to be conducted at the follow-up or discharge. Next slide. So here's another quick screenshot of the services received or planned services. So again, whoever is conducting this intake questionnaire, GPRA, you should just go down the list and whatever is applicable to your clients that you're serving, answer these questions, have them check off as much as they can. Again, put the disclaimer out there. If they feel uncomfortable about answering anything, they could choose not to. Next slide. So this is the sensitive question. So again, I've been saying disclaimers, but this one is a really touchy one. Again, for anyone who's not a clinician that has to ask these type of questions to clients, this could be really triggering some of these questions, dealing with violence and trauma or mental health concerns. Again, just go down the list, ask the questions appropriately. If you feel uncomfortable or the client feels uncomfortable at any point, they're allowed to refuse or skip the questions, but you handle that with care. And again, please refer this person if they're having any concerns to someone that can assist them or provide them additional support after the GPRA data is collected. So you don't want to trigger or harm anyone by asking any questions. Next slide. Okay, data collection staffing. So again, up to 25% of the grant award may be used for data collection, performance assessment, and infrastructure development. Grantees may contract with external evaluators for GPRA data collection entries. Grantees are encouraged to work with tribal epidemiology centers to implement this activity. GPRA data collection and data entry does not need to be done by clinical staff. So again, you guys can hire people internally in your program to complete this task if you need help with it. And if you're having any other concerns with this, please feel free to reach out to us GPOs and ask questions if you need additional help. Next slide. What's missing here? I'm going to turn this over on to Will. I think he picks up from here where I left off, but I think there was one other slide, but go ahead. If there are any questions at this point, we can stop and take a quick break and ask some questions, and then we'll pick up with Will.
Yeah, so I know that was a lot of information that Paul and Brittany just presented to you, but you know, we're happy to take some questions now. You can either enter them in the chat or just unmute and let us know what questions you have about the GPRA. And, you know, we can go back and look at another slide again if if anything was unclear.
Or tell us a scenario you're having or concern or something, Sure.
This is Michelle Weaver with the Mississippi Band of Choctaw Indians. So my grant is basically being extended. So it's a new grant, but we've been established for a few years. So I know we talked about before that you guys would prefer us to complete an intake and follow-up data. Now with that, are we back, like, is that intake for the same day, or, would there be backdating, or how does that work when you are a continued grant? Hope that makes sense.
Yeah, I might, let's see, need a little more information. So thank you for the question. When you say that you were extended, did you get a no cost extension, or did you get a new grant?
New grant.
Okay, so did you just start a new grant at the end of September?
Yes.
Okay, so we treat that grant and your previous TOR grant basically as separate grants. But for the purposes of GPRA, if you are serving the same clients under this new grant that you served under that previous grant, we have a certain way we want you to try and handle them with the data. Is that kind of what you're asking about?
Yes. Yep. That's
Okay.
exactly what.
Yeah, let's see. And Kate, could I ask you to go back to slide number 7? I know we covered this very briefly, but I know this might apply to a few of you who've had TOR grants before. Yeah, just let's see, one more back. Well, it was baseline intake interview. Keep going. That's it. So that second bullet there, if you have some clients who were getting served through your previous TOR grant, and then you're continuing to work with them under the new grant, you gave them this client ID number, right? So what you will do is complete a discharge interview with them under the old grant, and then complete a new intake using the same client ID number for that client under the new grant. So even though they may have been in treatment for some time, several months, a year, whatever, we're still asking you to do a new intake. Unfortunately, that's like the only way we've figured out to make this work. So you get credit for serving that client. All right.
Sounds good. Thank you for clarifying.
Yeah, sure. And then, you can get more information on this if you have calls with your GPO, either me or Brittany or Paul, just, you definitely bring that up and one of us will give you more info. And I see we had a couple questions in the chat. Let's see. So Meg Schneider asks, are there any consequences to grantees if clients refuse to answer intake or discharge questions? And how does the 80% response rate fit in with this? So first question, no, there are no consequences if clients refuse to answer. And, it's not like a condition. You should not be denying people treatment just because they don't want to answer the GPRA. Totally, voluntary for clients to answer these questions. And, they can refuse to answer all of the questions for any reason, and that's totally fine. The 80% response rate, if a client refuses to answer all the questions, I believe you still would get, if you reach that client, but they refuse to answer all the questions, I believe you will still get credit for completing that interview. But Sean or Darren, I don't know if either of you, I have some of my colleagues from SAMHSA's data department with me today. I don't know if either of you could just say for sure, if a client refused to answer all the questions, would they still get credit towards their follow-up rate?
Sure. Hi, good afternoon, everyone, at least those of you are Eastern and Central. This is Darren Fulmer, also evaluation and the Center for Behavioral Health Statistics and Quality. So I manage SPARS, where this data ends up when you've entered it using your intake through discharge milestones. So I believe the 80% refers to the SAMHSA CSAT follow-up minimum. So if you have clients who are refusing to answer parts of the follow-up tool, we'd ask is that certain items will have, yes, no, doesn't apply, refuse. And that gives us information. Even if they refuse it, we're figuring out, okay, it might be the items wrong, it might be items confusing, or it's insulting, or whatever that reason is. If we find, or you're finding that there are a number of indicators in the tool that folks are refusing to answer, it's good feedback. And you can let your project also know, and they can let us know if there's some aspects of the measure for our GPRA that is inappropriate for the services or for the use, the general purposes of the tool. The hope is that if you're finding that because you want to get credit and look at how your services are doing in your overall performance, we do offer a number of technical support options, including on the SAMHSA website, the Technology Transfer Center, one particularly that's focused for tribes, and there's others for data collection. And take advantage of those just in case you find that it's not necessarily the tool, or a blend of training or clinical or programmatic as well as the tool. So it's a long way of saying that you're not going to be penalized for making the attempt. The issue would be the more incomplete information you have on the services you provide, the more that could impact you being a program in the long term. So if that's a trend that you're noticing, it's also good to at least note that people are refusing. Maybe write down why, just so that it helps us, it helps you, etc.
All right. Thank you so much, Darren. And so then we had a couple more questions.
Sure.
Douglas Finney asked, what is the difference between follow-up and discharge?
Sure. So SAMHSA, for the purposes of this program, requires a 6-month follow-up. So 6 months from the point in time that you did the intake. And I think in one of your slides, you had like a little milestone. So let's just say January 1, 2021, theoretically. So there's a window of time 1 month before and 1 month after that anniversary. So let's say June 1, like May 1 would be the earliest that you can do it, and July 31st would be the latest. So you have essentially 90 days to try to reach the person, the number of attempts. Phone, I noticed that there's someone who asked, can you attempt by phone? And there was a dispensation that's still online on SAMHSA's website. And we know that there's certain programs because of COVID shutdowns or just the for the safety of your staff as well as your clients, you can use teleconferencing or Zoom or what we're using here to complete the interviews. Ideally, your follow-ups and your discharge, and I'll get to that in a moment, because most cases they may be doing their intake in person, but some of you may be conducting some telehealth. The discharge would be as you define it. So that's something we don't say your discharge is X. So if your client, say your length of stay is 90 days, well, that means you've discharged them before really the 6 months. So your discharge interview could take place in theory before your follow-up. And what the follow-up does is, for both SAMHSA and your purposes, maybe tracking the long-term how your clients or your patients are doing post your initial first day of treatment. Tell me that answers, if anyone has a follow-up to that.
Yeah, and then, oh, sorry, we had a question.
Yeah, about follow-up, please. Hi, I'm Christian. I'm a substance abuse counselor with the Karuk tribe in Siskiyou County. In section I of the survey, follow-up status, is that the entire, are there questions involved that I asked the client regarding follow-up status, and where would those be located? It's not just question 1 and 2 here, right? There's more to it.
Right. If you go to in fact, you don't even have to have a SAMHSA account. So let's just say some of you don't have one, but if you do, you could find a tool by going to the SPARS website, spars.samhsa.gov, and there's a hyperlink that says data collection tools and resources. I would recommend that for everyone listening as a review for not only you and your grantees. In there, if you we have it color coded and filtered. You can filter by CSAT, even though this program is managed by OTAP. It's a CSAT tool, and you can then select the client, we call it the client level tool, and scroll down that section I. And I think there's like 5 or 6 questions. First, it will ask, did you collect the interview? And then it branches off from there. And if you did, you basically would do the 6-month follow-up. And then if you didn't, then you might do, depending on if the client refuses to do it, what we call an administrative follow-up, which is very important because, again, we want to find out what's happening if folks are having difficulty either getting people to agree to complete the tool or lose track, etc. But there are definitely more than 1 or 2 questions.
Okay, so they can be found online if you follow the.
Yes, yeah, it's an OMB approved tool, so it's publicly available.
Same with discharge status. There'd be questions about that online as well.
Right, that's all part of that tool. So the discharge questions are in there's sections J and K. J is the discharge status, and K is kind of services provided. I'm sorry, William. I saw you.
I'm sorry for interrupting. We will send out we'll send out the GPRA tool that you should be using, along with a couple other things with the slides today. But Kate, could I ask you to go to slide 14, the client level interview sections? It's where we have kind of the blue figures there. There's like blue bubble, that one. Yeah. So Christian, basically the whole idea is that, we have a bunch of questions about kind of like resembles a clinical intake where you're asking someone about substance use. You're asking them about mental health, about family and living conditions, education, criminal justice involvement. There's all these questions that we want you to ask once at intake, and then we want you to ask them all again at follow-up. So it's not just that section I. We want you, if you see here, section B is required at each interview, C, D, and E, all of these sections, we want you to ask them all over again at the follow-up. So basically the entire interview is completed again, and then we're comparing the answers, on substance use. Is the person using less over the past 6 months compared to intake? Did they have improved living conditions? Do they have improved, education and educational or vocational situation, criminal justice status? So, it's not just the follow-up section. The follow-up section is kind of just to mark down, did you actually meet up with the person, contact the person to do the follow-up? Of course, if you can't reach them, then you can't ask them these questions, in which case you're just going to do those questions in section I. But if you do make contact with them, the point of that is to get all this information from them again, to do that kind of pre and post comparison.
Thanks, William. This is Darren. And the same thing that goes to the discharge interview. You would do if you do reach them and they agree to do the tool, you do the same sections A through G, but then you don't do I again, you would do J and K, which are the discharge questions, and K, which are the services provided.
And then we had someone ask, can we do, so yeah, Darren, you mentioned that they can do this over the phone. And then
right, whatever medium they can use, right?
Right. And we're going to show you how to use SPARS. So I think what most folks do is they print out a copy of this GPRA, complete the paper copy, whether you're talking to the person over the phone or in person, you write out the answers on paper, and then you take that and enter it into the computer on the SPARS system. You could just, take the answers that you're getting and enter them directly into SPARS and skip the step with the paper copy, but that might be a little complicated. I know that SPARS, it doesn't let you save your status, so you might get kicked out and have, you don't want to have to start all over or something like that. So at this point, there's not like a great way to, virtually complete the GPRA, so to speak. So do we have other questions at this point? Those are some great questions, so thank you, everyone. Okay, and there will be opportunities later on to ask questions if something comes to mind, but I think at this point then we are going to turn it over to Dr. Kathy Tomlin, who's going to talk to us a little bit about trauma and culturally informed data collection and applying motivational interviewing to your GPRA data collection.
Hello, everybody. I was just feeling a little overwhelmed just listening to all of the details. So this is a good point for us to talk about that. I also want to include, we have a guest who many of you know, Annette from Alaska, and she's going to also, she has some really good success with working with this instrument. So after I'm done, I'll turn it over. She's kind of more the expert than I am, for sure. So I just want to talk a little bit from a cultural perspective about feeling overwhelmed and with an instrument that is very directive and can be conceived as intrusive for people. So we really wanted to emphasize the importance of building a relationship so that people feel much more comfortable even responding to the instrument, but also preparing people to go into an instrument that's got a lot of questions and a lot of potentially sensitive information, including helping people to think about whether or not they want to make a contribution to their community by filling out these forms, which is I think an advantage in the sense that if people do choose to fill this form out, i.e. not do refused on everything, that they would understand that it's not just an instrument for the federal government, but it is an instrument that they can use within their community for prevention activities, for honing treatment, et cetera. So there's more application for it than just data collection for Congress or the federal government there, and we'll talk about that as well as Annette. When you think about, and I know there's a lot of experts on the call too, because I know there's some people that have been very successful or have been using this instrument for some time now. When we go through this information, think about how you prepare your clients for starting an assessment. I'll put /intake /data collection tool, or even a screening tool, because they tend to be very structured and a lot of questions. And what have you learned where you can prepare people in a culturally sensitive manner? So I'm going to throw that out to our participants today. And if you have any comments, feel free to respond by turning on your mic, especially those who have some experience, as well as throwing some ideas in the chat box. So we'll just take a few minutes to learn from our participants what you've done already that you feel has been culturally sensitive and helpful when working with this instrument with the people that you're using it with.
This is Tammy Dio from the Seneca Nation. We've been using the GPRA for a good 2 years for our first TOR grant. We struggled in the beginning. When I came on, they had been about a year into the grant, and they were struggling with, like you said, that confidentiality. They didn't want to have issues with rapport for the clientele. And so what we did is we started out, we kind of did a couple things. First, we made them like sign a release to make sure that they knew that what they were doing. Then we realized we really didn't need the release, and that we just really sat down with our clients and stated that, this is to help both, collect data, but also to help us figure out programming wise what we need to do as well. It also supports the grant that we have that provides, the programming supplies and things that we need to give you kind of support in the program. And so what happened was when we kind of really sat down and just were really honest with them, we really haven't had a lot of pushback. Probably I would say maybe 2% of the people that we have completed the TOR or the GPRA with have really said, no, I'm not going to do this. And we respect them. I have another grant too that I have, and we've actually done super well with that. That's through my behavioral health unit. And part of them, they just say, this is part of our housekeeping. Let's just sit down. They talk about what it's for. They talk about that, it doesn't track who you are, things like that. It just really helps the programming and figure out what is needed. We really haven't had a lot of pushback. And so they just kind of considered it as part of the housekeeping of the appointments that they have. And then their 6 months comes up. We're struggling a little bit with the 6-month GPRA. And so we're kind of trying to work out those bugs, but really we haven't had a whole lot of pushback with completing it from the way that we're presenting it. I don't know if that helps at all.
Yes, it does. Thank you for sharing. Anybody else want to chime in? So honesty, making it part of the regular process, letting them know how it helps the program. So making it more about local. Just a quick summary. Anybody use humor in filling these forms out? Sometimes humor helps. And also just explaining each section as you approach each section, so that you're constantly giving people permission to skip a section if the theme of the section isn't working for them, or just letting them know what's coming before you're asking the question can be helpful.
Kathleen, I think like you said too, just saying to them, if you don't want to answer it, that's fine. And we'll just move on to the next one.
Mm-hmm.
If it's something that's complicated or difficult, we'll table it and then we'll come back around and we'll address that, as we go forward. So I always like it when my providers do it in a session, just in case it does cause, some issues or concerns. So,
Mm-hmm.
they're just, it usually takes about 10 minutes and then they kind of circle back around if it was an issue.
Yeah. Yeah. Anybody else have any thoughts that you want to share that you've noticed has been successful?
The biggest problem that we've had is with people having enough time.
Mm-hmm.
So we've really worked very closely in our recovery clinic with the doctor and the nurse. And so they try to use different entry points that they cover the Narcan, that they cover. And so case management and entering into the TOR or SOR has been just a piece of that conversation with the doctor as well. We're going to have you see the people that are working with the grants, because they're doing statistical stuff, and this is part of what got our clinic started. And it also almost, I think, helps them to feel like they're part of why we started this clinic, and what they do is helping us to be able to have this clinic. And I think that they're so tired of hearing how they are such a drain on everybody and their families and everybody else. And I think that hearing that you're going to be part of the solution has been proactive for us.
Yeah, I'm glad you said that, Dorothy, because it is a TOR grant. And so it's opioid dependence that we're talking about, and it can have a lot of stigma attached to it. So yeah, think having the client or patient think of themselves as part of the solution versus, fear of being rejected because of the particular substance they're addicted to is really, really a nice affirming experience for them as patients, because often they are not treated well in the medical care system necessarily. Yeah. Okay, well, thank you for sharing. There'll be more opportunities to go through this. Let's move on to the next slide. Well, the SAMHSA team talked about confidentiality. So I don't know if we want to go into too much there, other than being aware of honoring tribal jurisdiction as it relates to programming, and making sure that the folks that support the tribe or the village are aware of what's going on, and that they can support that. Also, that there's a discussion about data collection within that community, because that can vary from community to community. I think I'm going to skip the others points, because I think they're kind of already been talked about, because I want to give Annette some time. In fact, why don't I just shoot over to Annette right now and have her offer some
Hi, this is Jen from
wisdom.
Dr. Adams' office. I was just following up with Julia to remind you have an appointment with Dr. Adams tomorrow at 1.
Yeah,
she video or in person,
inadvertently turned on her.
If you'll just give us a call back.
Yeah, there we go. Hi, Annette. Let's hear your wisdom, and then turn it back over to me when you're feeling completed. But let's hear your thoughts.
Can you go back to that slide that you were just at?
Yeah.
Yeah. Hi, everybody. My name is Annette. I am an MAT case manager for a rural clinic, IHS clinic on the Southern Kenai Peninsula in Alaska. And I am the TOR project director as well. And so maybe just to say what we're using our TOR grant for is to pay for my salary to do case management for our MAT clinic. We purchased fentanyl testing strips. We do outreach at our local syringe service program as well, to kind of talk about services here and just to be connected to people who are still actively using. And I volunteer there too, doing community education about treatment services, opiate use, opiate prevention, post-prevention. We use our supplemental grant to pay for our medical provider as well. And so when we are talking about GPRA and data collection, anybody who might be, who is accessing medication for addiction treatment, because it pays for my salary, our medical provider's salary, anybody who we might be using incentive money, we provide, sometimes we have gas cards. So anytime we have other grants as well, so that provide people or help with treatment accessibility. So anytime somebody's coming through our clinic, and we may or may not be doing copay assistance for people who are on long-acting buprenorphine, they're getting medication for addiction treatment, or any service that any of our grants are paying for, we get a GPRA at that first appointment. So at that intake appointment, my job is to go over the patient's medication contract, and I do an intake GPRA. Boom, first thing. But know that prior to that in-person appointment, we've probably had contact at least like 1 or 2 times. So I've already probably known that person. If I don't know that person and I haven't established a rapport, I might not do a GPRA at that first appointment. but it just, sometimes it depends. But I would say 8 out of 10 times I do a GPRA at that first appointment. And so we've definitely seen our GPRA numbers are up there because we've been able to do that. If they're just coming into the clinic to get fentanyl testing strips, or they're coming to the local syringe exchange to get fentanyl testing strips, we don't collect a GPRA. That's a prevention thing. And our Narcan kits are funded through the state opiate response grant. And those are provided to us by the state of Alaska. And that's a totally separate grant. So we don't do GPRAs on that. So we don't really work on that. But I think it's very important. Some of the questions, I have done GPRAs with patients who, I don't really truly, know very well. But I've definitely seen, when you're going through some of like the mental health questions or the trauma questions, having that, being able to take that as an opportunity to do referrals to behavioral health. And I do have behavioral health training as well. So I've definitely been able to have that as an opportunity. Some of the other questions, the questions where it relates to patient substance use, because we are an MAT clinic, we are also a low threshold care clinic. And so I think the conversation with patients has been extremely important of this GPRA is complete. What this GPRA, so the conversation that I have is, sorry, my ADD is really kicked in, so I'm probably going to be a little scattered this week. Is this, I'm gonna ask to do a data collection with you. We do this at intake and at 6 months, and then when you discharge. This is for the sole grant. We have grants that enable us to pay for our salary, to pay for our clinic services. They've enabled us to purchase fentanyl testing strips. So if at any point in time you or your friends need fentanyl testing strips, you can always ask. That's always free, to come here. You can get Hep C, you or your friends can come in and get Hep C treatment or Hep C testing at any time. We've made that available. We have a very extensive drug user health clinic. But asking these questions is not tied to your treatment. I'm going to ask you these questions and then I'm going to forget these answers. So please be honest. What these are is a data collection. Data collection is extremely important because it measures, it reports, it shows that the funds that we've gotten to enable us to do our job, that we're using those funds to do our jobs, that shows that it's not a measure. I don't think that it's a measurement tool. It just shows that we're using the funds to do our job, that we're serving our community. And so know that this might be a whole nother webinar, but so patients, and it's not tied to your treatment. So if you report to me, because patients know that they're going to get treated no matter what in our clinic, period, end of story. So if patients report on their GPRA that they've used Demerol and Percocet and heroin and methamphetamines, 30 out of 30 days, they know that they're going to get treated because they need to be treated. And then SAMHSA can see, hey, the community of the Southern Kenai Peninsula needs more services. They need housing services. They need more substance use treatment services. They need this, they need that. That is the importance of collecting the GPRA. If we don't collect those GPRAs and we don't collect those stats, SAMHSA, the CDC, the USDA isn't going to see that we have this issue in our community. So if we're not collecting these stats, the federal government's not going to know that we have these, that we don't have housing services in our community because I have an unhoused person who's using IV Demerol, right? Well, like these things aren't happening. So get your GPRAs, get them no matter what. And if people are refusing, then mark it. We need to know these things. So and then the other thing is, so I usually collect the intakes and then we have another person who does the follow-ups because I probably have like 10 intakes a week. So I don't have necessarily time to do the follow-ups. And I always tell a patient when I do the intake, somebody else is going to call you to do the follow-ups. And like I said, we have a couple of different grants that support it. So we have a coding system that says, that the TOR grant supports these services. this grant supports these services and this grant supports these services, and we've coordinated those amongst the 3 different project directors for that. I have lots to say on data collection. Do it. I'm sorry, I'm a national TA provider, and there's a huge push to do data collection. If you don't do data collection, you can't get the funding to do the services in your community, whether that's an inpatient, whether if your dream is to create an inpatient treatment center in your community, housing services for the unhoused who use substances, you will never get that funding if you don't do your GPRAs. And that's my piece.
Thanks, Annette.
Yeah, thanks, Annette. I always love your energy and your specificity. So let's talk about not what I mean. I think Annette and others, you have your way of going about gathering that information. What I'm hearing from Annette, which we're going to move into what motivates people, and what I'm hearing that is motivational is how do you make something that is, you know, this format that is culturally not necessarily the best format, but how do you make it local? How do you motivate people to want to work with you to complete it so that you can continue to provide services to your community? So I want to move on to a format that has worked in the research world. And so this is really going to be a share screen. So I'm going to pop people out and pull up. And this is a handout that we'll provide to you after the training. So this is a 2-page handout, but it's called the MI Interviewing Sandwich. Some of you may already know about this instrument. It was originally, it was actually developed decades ago, adapted from the Motivational Interviewing Skills Code, which was an instrument that has been used over the years to help people master their skills with motivational interviewing. So, and I'm going to move over to the second page of this and increase the, yeah, hopefully not too much so that you can't see it. Increase the zoom. So there's the front page is just information about it, and this I just want to focus on the sandwich effect. So if, and this is a big if you're finding people in your community resistant to participating in data collection, your goal would not be to force them. Now, I want to be clear about this. This is a process where you're trying to help them be more comfortable if they choose to engage with helping you complete the data collection, because it can be a little daunting. So the MI Sandwich basically has 3 steps. Step 1 is where you're building rapport and you're engaging with the client around, just like Annette described. This is what it is. This is why we do it. Here's and others, you know, here are the different sections. If there's something you don't want to fill in, that's okay. It's not tied to your treatment. So these are some of the MI skills that you would use. And I know a lot of people already have training in motivational interviewing, but I also wrote it out if you haven't had training, that you can kind of get the gist of it. So step 1, you kind of basically, depending on your experience of filling the GPRA out, you divide your time into sections. So 15 to 20 minutes is really devoted to step 1, where you're just noticing as you introduce this instrument, you do that conversation, but you're also asking them how they feel about it, and more importantly, with something like GPRA, throughout the process, you're asking permission to continue, and so it's the empowering agency with people. To at any point say, you know, I'm tired, or I don't have the time, or I'm feeling pressured about something, that they know that they can participate, but that they don't have to go through the whole thing. Then there is a statement, a transitional statement from step 1 to step 2. where basically you summarize their understanding of what the data collection instrument will be, or the assessment, or the intake, whatever instrument you're using. And then you ask a permission again, and you make sure that they understand. This is where you would be talking a lot about confidentiality. You would be talking about, I personally think it's important to talk about, especially in tribal life, who is going to have access to this data locally, because that's a big issue for a lot of people entering care, and it's a sensitive issue. So if someone participates to fill this out, who locally will have access to it, and how is my confidentiality protected? And you summarize that before you start asking the questions. So step 2 is the data collection, and I think people have gone through that process. I based on what section people are in, I would continuously say, are we ready to keep going? Is this still, how are you feeling about it so far? And then if and when you get to the more sensitive questions, the client will tell you which questions are sensitive. It could be a substance use question. It could be the mental health section, section F. But you do a friendly reminder that at any time they don't want to answer because they're getting triggered or because it's too sensitive, that you acknowledge that. And then you do another, once your data collection is over, you do another transition, step 2 to step 3, where basically you're just saying, thank you for taking the time with me to fill this out. Here are some recommendations if there's a need for a referral to treatment. If not, provide necessary resources as needed, and invite them to continue to work with you to fill the instrument out ongoing based on the schedule. So we will. So that's the MI sandwich that was developed years ago, and feel free to use it as you see fit. And those of you who already have a process that's working, it's just continue to do what's working, while you're also being culturally sensitive with not only tribal life, village life, but also with opioid dependence issues, because a lot of our clients have not been treated well for their opioid dependence. So those are some thoughts to share with you. I'm ready to turn it over, and obviously, if you have any questions, we're here to answer. If you have any thoughts or questions about what was just presented.
Okay. Yeah, thank you, Dr. Tomlin. That was great information. I know, even though the GPRA is not a clinical tool, it was kind of based on some clinical tools, and it includes some pretty sensitive questions. So anytime you can incorporate some of those clinical techniques like motivational interviewing, definitely we encourage you to do that. And we had a couple comments, about follow-up. And I think Emery Nault, he says, one challenge is locating clients after the initial GPRA. Phones may be disconnected, moved out of area, are some of the challenges we are experiencing. So yeah, and I definitely understand that. And, we just ask you to kind of do what you can. And, if you're able to get in touch with them via phone, they've moved out of the area, but you can still reach them via phone. You can do the GPRA over the phone. Somebody else had mentioned incentives. I know that can help. If you let clients know early on that you're going to be asking them these questions again, kind of wherever they are, whether they're still in the program or not, and that, you'll give them a gift card incentive for participating, that can help. So you can use up to $30 non-cash incentives for that follow-up. And so someone had a great idea here. Sarah Bear says they provide $20 Walmart gift cards that prohibit the purchase of alcohol, tobacco, and firearms. So that seems like a pretty good idea. Someone, Josie Deutsch, said local grocery store and gas. That's a good idea too. Oh yeah, Jason, please be safe. Jason says they went under a tornado warning there. So, Annette, oh yeah, and thank you, Annette, for all of your great insights. We appreciate, hearing from people who are actually doing this work with the GPRA. And yeah, we think we have forms that you can find on the SPARS website that kind of like a locator form, we call it, where you're collecting not just the person's cell phone number, but, do you have Facebook? Can you give us another number we could potentially reach you at if this phone, is no longer active? So Annette said, that she asks, is there an alternative way to reach you? Facebook, family, friends, etc. So lots of great information. And, obviously it's going to depend on what you're doing. If you're providing MAT, like if someone's a methadone client, you'll probably have an easier time seeing them on any given day because they'll be at your clinic than if, they're in transitional housing or something where you don't really see them that often. So, we take that into consideration, and the 80% follow-up rate is just kind of something we strive for because, that data is important for us, as we have explained, just in terms of trying to demonstrate the impact of the program. And so, yeah, let's see, Kate, could you pull up the slides again there? We just have one more section today. We saved the driest, the most tedious section for last, and that is SPARS and GPRA resources. So you can go on to the next slide. So we talked about the GPRA, and then you might ask, well, what do I do with the GPRA data once I've collected it? And so you will enter that data into a website called SPARS. SPARS stands for SAMHSA's Performance Accountability and Reporting System. And that allows you to submit data. You can also download data to look at and use yourself. You can generate reports, and we'll show you how to do some of that. There's other resources in SPARS. You can request technical assistance from SAMHSA on how to do the GPRA. And then, we are hoping to start having some trainings soon about SPARS and about the GPRA. Next slide, please. So this is what SPARS looks like, and there's the web address. So when you log in, you should see this web page. You can go to the next slide. And so there are whole trainings on the SPARS website on how to do all this stuff. And we have a link to those in this slide deck, but we're just kind of giving you an overview today of where to go within this website. So TOR grantees, once you enter SPARS, if you've collected some GPRA data and you're trying to upload it, you will go to the tab that says data entry and reports. And then you'll see these three tabs for CSAT users, for CMHS users, and for CSAP users. So you're going to want that first one because that's where TOR is kind of located within SAMHSA. CSAT users, Center for Substance Abuse Treatment. So you'll go to that and click CSAT data entry. Next slide, please. And then once you're there, on the left-hand side, you'll see a number of options. So under the drop-down button for data entry, you're trying to enter data, so you click data entry, and then you'll click on services. And because this is we consider this a services grant. And then once you click on services, you should be able to search for your grant. You'll see a screen similar to what you see here, and you'll need to know your grant number. So you should have a TI number. And if you're unfamiliar with that number, you can ask your GPO and we'll help you with that. And we could even do like a screen share with you now with Zoom and walk you through these steps. But once you enter your grant number, you'll see in that table below where it says treatment drug court, you'll see something like, tribal opioid response grant, and then your tribe name or your organization name there, and you'll be able to click and select your grant there. And then next slide, please. Yeah, and so for a full description of how to enter your client intake data, you'll want to check out the recordings that we link to here. And we had a question. What if you have what if you've done a client intake before you're set up in SPARS? So that's totally fine. You know, there's no due date for entering your GPRA into SPARS. So as soon as we get you set up, you know, just hang on to that intake. And then once you're set up in SPARS, you'll be able to upload it. So in addition to entering data, you can use SPARS to run reports, which, you know, so I think one thing that's that we don't do a great job of communicating at SAMHSA is, you know, that this data is not just for us to collect. It's also for you all to use, you know, to show, you know, stakeholders the impact of your programs. So you can run reports and generate some charts on the impact of your grant, you know, on the services that you provided based on the GPRA data that you enter into SPARS. So when you go into SPARS, you know, the same process as before. Instead of clicking data entry on that left-hand side, you'll click click reports. And then if you look through there, you'll find a number of different reports based on, again, the data that you put into SPARS. Next slide, please. And then, you know, TOR grantees, you can generate charts and visualizations under that visualizations tab. And I think if you go to the next slide, I think we have some examples. So these are just some basic ones. You know, you can generate demographics tables. So, and then you can download these and you know, put them into a PowerPoint or whatever, your own report, strategic plan. So this is automatically created for you based on the data that you enter. Next slide, please. And then this, you know, if you have been collecting diagnosis data, you could put together another chart like this using the TOR, you know, the GPRA data that you've entered. Next slide. And then, you know, if you've been entering follow-up data, you can also show reduction in some of those, you know, you can show the comparison from baseline to follow-up. So, you know, there was a 46% reduction in injection drug use among clients. This is just an example from, you know, that was taken out, I guess 2018. I think this is just kind of a mock example. This wasn't really from an actual grant program, but, you know, and then it has some data on some high risk sexual behavior and showing, you know, that there's been a reduction in all these things, and unprotected sexual contact, unprotected sexual contact with an individual who has HIV or was yeah. So you can generate charts like this about substance use, about mental health, you know, housing, criminal justice status. So pretty helpful charts that can demonstrate the impact of this grant. It's all in there. All you need to do is, you know, enter the system and go to these sections, and you can easily generate these charts and download them. And so someone had asked, I thought the GPRA data needed to be entered within 7 days of the intake. Is there a timeline to get client from a previous TOR grant entered into SPARS for a new grant? So we do ask you to try and enter your data within 7 days. That's true, but you know, there is no due date. Like you can still enter it after 7 days. We just ask you to try and enter it within a week so that, you know, we can see where you're at, so that the data we see is current, because your GPRA is one way that we are able to go, you know, to see how things are going without having to speak to you, you know, every week. So it's just one way that we're able to kind of look at how things are going with your program. But, you know, if you're not able to get a GPRA entered within 7 days, that's fine. You'll still be able to enter it the following week or the following month. And is there a timeline or a limit to enter clients from a previous TOR grant? No, there isn't, but you know, you should aim to at least complete that intake as early as possible. And then, you know, once you're set up in SPARS, you can enter that data. Next slide, please. And so here is the SPARS help desk information. That has changed recently, so make sure you have the current help desk information because the phone number and the web address both changed. But anytime you're having issues getting into SPARS, you can always call or email the help desk. There's a whole team of people there, you know, whose job it is to help grantees using SPARS. Next slide, please. And so as far as next steps, you know, if you're a new grantee, we ask you to discuss specific data collection requirements with your assigned GPO to determine GPRA targets. So if you are only doing prevention with your grant, you know, maybe you're only working with youth, you're only working with elders, and you're just doing education, you may not need to do the GPRA because the GPRA is really for you to complete with people who are in treatment, you know, so it may not actually apply to your program. So that would be the first thing for you to figure out. And so you want to talk to your GPO, myself or Brittany or Paul, to figure out, you know, whether you even need to do the client GPRA. The second thing, if you do need to do the GPRA, you know, the second thing would be to review the GPRA itself and these other documents that go along with it, just to familiarize yourself with this material and this process, because, you know, it's a little complicated. And then, you know, if you should be doing GPRA, then we ask you to begin collecting that information as soon as possible and then entering that into SPARS. And, you know, of course, anytime you have questions, just talk to your GPO. And I should just mention again, you know, if you're doing the naloxone, if you're purchasing and distributing naloxone or, you know, / Narcan with your TOR funds, that's another thing we want to know about, you know, through GPRA. Next slide, please. And so to get you set up in SPARS for your new grant, even if you were in SPARS on an old grant, we ask you to complete this form. Basically, this will link, you know, your new grant with your SPARS account. So if you haven't gotten a copy of this, we'll send it out. Usually we try to send it out, you know, at the beginning of the grant cycle, but we'll send this out after the webinar today, and you'll just complete this and send it into SPARS, and then they will link your, you know, if you're new, they'll create a SPARS account for you. If you already had an account, then they will link that with your new grant, and you'll be able to go in and enter data for your new grant. And this is also where you will let SAMHSA know, you know, what are your target numbers for your, you know, how many clients do you plan to serve and do GPRAs with? So if you're doing a Suboxone program, you're going to see 50 people each year. And, you know, therefore you'll try to complete 50 GPRA intakes each year. You'll enter that number into this form, and then that will go into SPARS. So we had a question: can a GPRA be partially entered and then go back and finish? As far as entering it into SPARS, I don't think it lets you save your progress, unfortunately. So I think you need to enter, you know, the complete GPRA all at once. So the next slide. And here are some resources. As I mentioned, we have some webinar recordings and you know, how to enter GPRA data into SPARS. There is a SAMHSA resource that's a little dated at this point, but it's Guide to GPRA Data Collection Using Trauma-Informed Interviewing Skills. And then the three things at the bottom, we will send out, you know, the GPRA tool itself and the question-by-question guide and GPRA frequently asked questions. So all are very useful. Next slide. And here is the contact information for the 3 SAMHSA staff working on the grant. And I think that's all. Next slide. So yeah, we can take some questions now. I think we've reached the end of our presentation. So let's see. I know it's a lot of material that we covered, but you know, we're here to help you understand this stuff, and definitely this will give you a good place to start, and you can, talk about this with your GPO on your next call.
I got a question. I missed the part that you said there's some clients that we don't have to fill out this GPRA with. And who was that? What did we refer to? Like which clients?
Yeah, thank you. That's a good
I'm
question.
sorry.
It's definitely worth going over in more detail, because I think we kind of just glossed over it. But, the GPRA, it's basically a survey that you complete with someone who's entering treatment, someone with a substance use, someone with a substance use disorder. So, TOR allows you to do a bunch of different things. And maybe, I know some projects aren't really using TOR money to do treatment. They might be just using TOR money to do like prevention education. So you're just working with an audience. Maybe you're doing trainings on opioid misuse and overdose with community, with kids in schools, and you're seeing dozens of kids when you do these trainings. You wouldn't do a GPRA with those people, with that audience, because the GPRA is kind of intended to be a tool to measure like the improvement someone has over the course of time in treatment. So if you're doing prevention activities only, then you wouldn't have to do this GPRA client tool, which is more so for treatment.
Okay, thank you.
You're welcome.
And William, just to clarify, so if we are distributing naloxone kits, which myself and my coworker are being trained to do here shortly, we do track that in GPRA as well, correct?
Yeah, thank you for that. So if you are using the TOR grant to buy the kits, then yes. But if you're purchasing them through some other funding source, you don't have to report that to us. But SAMHSA just wants to know, how much of this funding is going towards purchasing naloxone. And then every 90 days, so once a quarter, you'll go into SPARS and let us know, okay, we purchased 200 kits and we distributed, 100 of them. So that's what we're asking you to keep track of and report to us.
So is it fine if we get those kits through a different funding source, just to note that we're distributing? Is it okay to report that?
So if you're getting it through some other funding, then you don't have to report that to us through SPARS, but you could, mention that through your progress report. So separate from GPRA, because with the GPRA, we're just trying to, count up the number purchased through the grant.
10-4.
Thank you. All right, let's see. We have a couple questions in the chat. Yeah, so Tamara Perkins asked, the GPRA form expires on February 28th, 2022. How far in advance will we have access to the new one? That's a great question. I hope that we will have the new, I'm not kind of privy to all the details about when the new GPRA form will be out, but I hope that we will have the new one ready to go, before that expiration date. And, there might be a little kind of transition period, but we will, be announcing more details on that sometime in the new year in February. And yeah, Kate had sent, let's see, I think that's the slides, right? And Katina Salmons asked on page 13, where it asks if the client received inpatient, outpatient, or emergency room visits, does that include the intake they are doing with us? So let's see, I'd have to actually take a look here to the actual survey itself. Yeah, that may be something, let's see, we follow up with you on. And then Linda asks, what if patient has admitted to currently being high, but is there to complete the GPRA? Does the GPRA continue So, you know, you don't necessarily have to complete the GPRA that very first day. You can complete it within, you know, 2 to 3 days. I think, you know, it may be worth waiting till the next time you meet with that client, just given, you know, you want to try and get accurate information from the client at baseline. So if they are currently high, you know, you can wait until the next time you meet with them to try and do that survey again. But yeah, for that other question, we will follow up with you, Katina, just so that we can actually take a look at the GPRA. But let's see. So do you all have other questions? These are great questions, and I think you know, we've definitely appreciate your participation in our webinar today. Okay, so someone asked a question here. So there is no penalty for entering the intake GPRA late past 7 days that will impact the 80%. So there is no penalty for entering the GPRA into SPARS, you know, after 7 days. No, and the 80% is the follow-up rate, not so much. That's not really the intake rate, but that's, you know, that refers to the percent of clients that we hope you will reach to do that follow-up. You know, 8 out of 10 clients. I know that's ambitious, but that's just kind of SAMHSA's expectation across all the grants. All right. Any other questions before we conclude our meeting today? So Emery asked, when will we know when the supplements are awarded? So that's a good question, not directly related to GPRA, but since you're all here, if you received some supplemental funding with your grant, so, you know, that funding has been awarded to you and you're approved to spend that, but we are working on, you know, getting you a new notice of award, approving your budget documents. And so if you're going to wait on that, then we will be working on that for the next 2 or 3 weeks. So by 3 weeks from now, we should hopefully have some, you know, written approval for you on your supplemental budgets. And then, is there a different process for conducting the GPRA on minors? No, there is not a different process that SAMHSA has in place for conducting the GPRA on minors.
It might be a good topic to do a webinar on, which is young adults and adolescents, late transitional age adolescents, because there are different things you have to consider with younger age groups, and we could talk about that as you want to talk about it, which is an area of focus in my career.
Yeah, there probably ought to be a different process.
Would that have to go through an IRB? I don't know if you're doing research, yes, but not to do an intake form or data collection form. But if you're going to do research, yes. And also, yeah, how about family and the role of family in the treatment of minors? Yeah, those are really, and it depends. I think that's a very culturally relevant question, because I think families are a big issue, both wanting to help families and also actively using adults around kids or other relatives. So we're thinking about doing a family training. And so we'll take those thoughts into consideration.
Okay, let's see. Yeah, definitely. You know, SAMHSA, apart from our GPRA, we ask every grantee to, you know, comply with our participant protection standards. And, you know, when you all submitted your grants, you submitted some details on how you would, you know, meet those standards. And so, you know, that includes information on working with adolescents. But definitely, you know, bring that up with your GPO because that is an important topic. And we want to make sure, you know, given the content of the GPRA, that we are, you know, taking every precaution and care when working with young adults or youth.
And Tammy Perkins, she's bringing up a point in terms of IRB issues with Indian Health Service. So yeah, thanks for sharing that information. You know, typically you don't have to, but with adolescents, under adolescents defined as under 18, there to check with your local IRB board in terms of just doing data collection without the purpose of doing research. That would be a good thing to check out. Thanks for the info, Tammy.
All right. Were there any other questions today? Well, thank you everyone again for your participation. We really appreciate it and appreciate all the work that you do on this grant. And if you're, you know, just starting with us on the TOR project, we're, you know, really looking forward to working with you and making your project a success. So, you know, please reach out to one of your project officers, one of us, if you haven't spoken to any of us yet, and we'd, you know, love to hear from you. And again, we'll be sending out all the materials, you know, the recording and slides and everything else in another day or two. So you all have a good rest of your day. Thank you.